So today I'm going to discuss about sinus tachycardia along with what exactly is meant by pathological sinus tachycardia. So before we jump onto the pathology, let's just understand a few things which are basic, and those are about sinus tachycardia. When I mean sinus tachycardia, it's got two words, right? One is sinus, one is tachycardia. Sinus means it originates from the SA node, and tachycardia simply means the heart rate has to be more than 100, as I mentioned here. So when the rhythm is originating from the sinus SA node, you have what we call as rhythm, which is sinus. And when the rhythm originates from the SA node, you have peculiar P wave in which there's RA depolarization first, which is followed by LA depolarization, and that equally constitutes to P wave. So if the impulse actually originates from somewhere else, the P wave morphology is gonna differ. So this is your routine P wave and how it looks. And when it originates from the sinus node, we call it sinus P wave. So when the sinus P wave along with heart rate being more than 100, we call it sinus tachycardia. So what are the features of clinical findings in ECG when we talk about SA nodal sinus tachycardia? So it has to be sinus P waves, as I mentioned before. The heart rate has to be more than 100. The normal heart rate, which ranges between 60 to 100, and heart rate in tachycardia has to be more than 100. So every P wave has to precede before QRS, right? So every P wave precedes before QRS, and that is normal, and that also is followed in sinus tachycardia. What is important is the PR interval, which is more than 0.12 seconds. So now you have to know that the PR interval starts from the start of the P wave and start of the QRS. We can actually call it PQ interval, but for the namesake, it's called as PR interval. And normally it ranges between 0.12 to 0.02 seconds. So yeah, similarly, it has to be more than 0.12 seconds. That's what is important in sinus tachycardia. Next is how the morphology is gonna be in most of the leads. So, as you know, the one, lead 2, and the AVF, these two being inferior leads, and the lead 1 being the lateral lead. These are also called as frontal leads, right? So, because they are placed in frontal plane and they are looking at the heart from the frontal plane. So, when these gates, then the sinus impulse is traveling towards these leads, you're gonna see that the upright deviation is traveling towards the leads. So the P wave is gonna be positive in 1, 2, and AVF. And what you need to know in the horizontal plane, which is when you take the cut section of the heart like this, your leads, your chest leads, which are V1 to V6, are placed like this, correct? So SN node, which is situated a little bit posteriorly, when it fires up, the signal is actually going anteriorly. So even in the anterior and lateral leads, in the horizontal plane, you're gonna see P wave, which is going to be positive deflection. So considering all the characteristics of sinus tachycardia, we have P wave, sinus P waves, heart rate more than 100, PR interval of more than 0.12 seconds, and the upright P wave in lead 1, 2, and AVF in the frontal plane, and V3 to V6 in horizontal plane. This is just a pictorial presentation of how the sinus impulse travels towards SA node and the RA-LA depolarization causing the sinus P wave. So now we know what is sinus tachycardia. Let's just jump on to quickly revise the causes of sinus tachycardia. It can be physiological conditions like your exercise, emotion, or fear or anxiety, like the way I'm having right now while I'm teaching you guys. Or it can be pathological etiology. Most common finding in PT, that is pulmonary thromboembolism, is actually sinus tachycardia. Also, you will see it in the patient who is thyrotoxicosis, pulmonary edema because they are going to be breathless, hypoxia, that's going to trigger tachycardia, anemia, less blood, more requirement, and infection actually, when it raises the temperature, it also raises the heart rate. For every 1 degree Celsius rise, you have almost 10 beats increase in your heart rhythm. Shock against a compensatory mechanism, and hemorrhage anywhere in the body, which will ultimately result in hypovolemic shock. Pharmacological causes like your atropine, which is your anticholinergic. So anticholinergic no vagus, no parasympathetic supply. You're gonna have sympathetic overdrive, and that's gonna trigger tachycardia. Hydralazine causing the afterload reduction. There's vasodilator, then venous pulling, which is gonna cause tachycardia. NORAD and adrenaline, which are again your inotropic agents. They're gonna stimulate beta 1 receptors present on your heart, so you're gonna have tachycardia. So what you need to know about sinus tachycardia, it accelerates gradually and also decelerates gradually. And also it's always non-paroxysmal. It cannot just occur suddenly and disrupt suddenly. That is what is something pathological. So let's just quickly understand the mechanism why SI node is the pacemaker, and also how the anatomy of the SI node is. So we all know that there is diastolic slow depolarization, which is phase 4, that is responsible for the pacemaker cells. So every pacemaker cell has action potential which looks like this, and it is the depolarization phase which is fastest in the SI node among all other conducting pacemakers in the heart. So that is why SI node is the pacemaker. Now, coming to the SI nodal anatomy, SI node usually not there's no single point from where the impulse is originating. You have cranial portion as well as caudal portion. So even in the SI node itself, the cranial portion has the faster rate as compared to the caudal. So there are, when the heart rate actually increases, it goes from the caudal region to the cranial region. So there are therapeutic indications where we can selectively ablate cranial portions of the SI node as well.